All right, guys, we'll get started. Thanks for joining us at the Society for Brain Mapping. I'm really excited to be here. This is my first year as being part of the Society for Brain Mapping, and it's really exciting. One of the reasons that I personally decided to join this group, whereas I'm not, I'm in private practice. I'm not a guy that is very heavily affiliated with these different organizations, just because of the fact that I am interested in so many different things. One of the things that really excited me about what these guys have been able to do is put together an organization that welcomes all kinds of ideas, all kinds of futuristic thinking, outside the box thinking, and not that same narrow-minded silo thinking that really does bother me as a physician. And I feel that if we can't talk to our colleagues that are doing some things that are outside of the box, we just really can't get to the next level. And the truth is, in our country, we spend more money per capita on our citizens, and I know some of you are not from the U.S. In the U.S., we spend more money per person, but yet every chronic disease is getting worse. And so we have to think about doing things differently. And so Dr. Kata, he asked me to talk about the future. Where is spine going? And I have a lot to say on that because I'm thinking about it differently. Now, if I was asked to give this talk about 5 years ago, I would sit here and I would show you all kinds of slides about minimally invasive spine surgery and this technique and that technique and sagittal balance and all these other things. Those are all important, and it's a huge part of doing really good surgeries when people need surgery. But we really need to think outside the box. And so I thought today I would give a very general overview into some of the things that we're going to be thinking about. And the truth is, we're going into a whole new era of care, not just in spine, but just in medicine, personalized medicine, and the advent of all these things I'm going to talk about today, from stem cell therapies to nanosurgery to light therapies to peptides. All these things are going to completely change. 10 years from now, you guys will be at this meeting. It'll be completely different the way we treat most of these diseases. And it's very exciting to see what is possible when we think this way. And I think that this organization does an amazing job of really thinking outside the box. So let's focus on spine care. I mean, really, I'd love to talk about all of medicine because there's some fascinating stuff going on. But spine, it's a massive global impact, right? 1.2 billion people are affected by spinal conditions. It costs trillions of dollars if you look at the entire world. It's a huge problem. There's a huge burden of disease. And again, in our country, it can bankrupt us if we're not careful about the way we treat these diseases because they're out of control. Just to give you an example, in the United States, we spend $4.4 trillion on mostly sick care. About 10% of what we spend on is preventative care, and the other 90% is at the end stage of people's disease. So there's so much work to do. So where's that paradigm shift? We have to really change our mentality and what we're doing. So really, one of the biggest things that has excited me, and I know excites a lot of people in the audience today, is this concept of regenerative medicine. So when I say regenerative medicine, people automatically think it's just stem cells. It's not just stem cells. We're talking about light therapy and peptides, which are these small amino acid chain molecules, one of which you would know is insulin, GLP-1s. Those are peptides, but there's other peptides that can really dramatically change the way that things work in the body with inflammation and other things. There is a rapidly escalating ability for us to harvest some of these technologies, and it's moving pretty fast. I mean, it's beyond the scope of this to get into all of them in great detail, but the scientific-based approaches that people are doing right now in the world of stem cell treatments, in the world of peptide management, in the world of light therapy, photobiomodulation, which Every time I bring up light and laser therapy, most of the people in the audience have never used it. They've never thought of it. Maybe they've seen a red light bed at the gym or something, but they don't really know how the technology works and how potentially it can make a huge impact. So when we talk about stem cells, what we talk about specifically in the US are like really targeted regenerative technologies. So something called bone marrow aspirate concentrate. So basically you harvest bone marrow, and you spin down the cells, you take the cells you want, and you stick them where the damage is, okay? And these are mesenchymal cells, cells that can really change the local environment and create healing, decrease inflammation, and stimulate repair. There's adipose-derived stem cells. You basically harvest fat, you take the cells from there. There's PRP that you guys are very familiar with, platelet-rich plasma. That's been around for a long time. That's been pretty accepted. And there's something called alpha-2 macroglobulin, which is a plasma protein that can really decrease inflammation and swelling. And when used in conjunction with some of these other modalities I'll show you, can really help. So I just had a phenomenal discussion on my podcast with a clinic from Mexico that's doing whole body stem cell therapy. And so they're replicating cell lines and they're giving the stem cells back. And the potential for that in so many diseases, including autism, all these neurodegenerative conditions, it's massive. We unfortunately are hamstrung in the US. We really can't do a lot of these things because we're really not allowed to replicate cell lines and then given back to people. It's a very stringent regulations on that, but they are able to do it, like in places like Mexico, with excellent results. So when I talk about it, we're talking more about targeted therapies. And so if you take these cells, again, outside of the scope of this lecture, I'm happy to answer any questions, but if you take those cells and put them in targeted areas, so for example, people that have osteoarthritis of the knee, taking stem cells and injecting them into the bone itself, into the cartilage area, into the joint can create dramatic healing. And even myself as an orthopedic surgeon, I don't want to say I was misled, but there was a lot of pushback against utilizing stem cells, even targeted stem cell therapy, which has such excellent results in the literature. Just Google it. You can look it up yourself. Even people would come to me and say, oh, I'm flying to this place. I'm going to this place to get my stem cells. And I'm thinking to myself, why are they doing that? You're being taken advantage of. Why? Because I was in that fixed silo mentality. So we have to come out of that. I will tell you, this stuff is really exciting, and I think stem cell therapies, and again, this is an entire lecture on its own, is radically going to change the way we treat things. If you look at just using bone marrow aspirate, there are studies, and you can just read it on the screen, that shows that you can increase disc height by 60%. The pain reduction's dramatic. The MRI signal changes. The ODI scores are improved. This is really exciting stuff, but I can tell you, when we go to our conferences, and that's what I really like about this particular conference where it's really out of the box, we're not talking about these things as spine surgeons. We're just not. It's so far down the list, but yet so effective and excited, to be doing some of these things. And if you combine, like, for example, PRP with alpha-2, you get tremendous results. Again, another study, it shows pain reduction, ODI improvement, all kinds of pain relief. But again, if we don't talk about these things, we can't promote these things. And in synergy, it's incredible the way they work together. One thing helps another thing. So how are we thinking about mixing like peptides with stem cells with light therapy? This is really the future. And it's really exciting to be able to bring some of these things to light. So one of the things I'm really passionate about is the future of spinal cord injury management, and it's really exciting. Some of the studies I'm going to show you the two big, and they're small, but they're the two that are now being quoted quite a bit. So people come in with spinal cord injuries. What are some of the downs? What happens? You get this secondary injury. Right? The spinal cord's pinched, it's injured, and then you get this inflammatory bomb that goes off, and it just continues to perpetuate. So what about a situation where we take stem cells and we put it along the spinal cord intrathecally, and allow those stem cells to do their work. Now, again, these are things that are not talked about enough. But let's look at the studies out of Yale and Mayo Clinic. So the Yale study, they looked at utilizing the bone marrow-derived cells, and they had 13 patients with spinal cord injury. They had a 50% improvement in their motor deficit. This was highly statistically significant when compared to other populations. And then they compared that to the preclinical data where in rodents were recovering. It's pretty fascinating that you could put these stem cells there and have some recovery. So this really needs to be offered to our patients, and I wish we could offer this at our level 1 trauma center where we're working. How hard is it to just take somebody's stem cells and stick it there where the spinal cord is injured? There's really not a lot of downside, and there's a tremendous amount of upside. If you look at the Mayo, and Mayo's in our, that's in our backyard up in Minnesota, they had improvement in their grade of injury significantly at their 2-year follow-up. Their sensory and motor scores improved, and they had very mild, look at the side effects, a headache and musculoskeletal pain, no serious adverse side effects. What is slowing us down from doing this? It's that we're not really talking about this enough. I encourage you guys to go and really look at that study. It's really fascinating, what they did. So the next topic, and again, I'm going to go, unfortunately, I have 30 minutes, so I have to go kind of quickly through what I think is kind of the next iteration of stuff, or peptides. So peptides, you're really going to be familiar with them. So the one on the left, you guys all know, it's insulin, right? Peptides were discovered in 1902, and then in the 1920s, we discovered, what was behind insulin. So there are these short-chain amino acid molecules. So insulin is 51 of them. And then the next one, and next to it is a GLP-1. GLP-1 is, we hear that on every other commercials about GLP-1 these days, including the Super Bowl commercials. So peptides are being popularized. But what about the peptides we don't hear about? If you guys listen to any of these longevity programs like Joe Rogan or any of these other guys, you're going to hear this BPC 157 over and over. It is a very effective peptide. If you just look at, for example, a tendon healing study, one example, it improves tendon healing by 25%. It can improve muscular healing, it can improve other healing. Why are we not using BPC 157 in the postoperative period? These are the questions. I want people to start asking these questions, and we need to answer them. And that's what a society like this allows us to do. It allows us to talk about these types of topics. There's another peptide. It's called VD11. I don't expect any of you to ever have heard about it, but it actually promotes axonal growth in the spinal cord. And a study in 2023 definitely showed some promise, initial promise. We need to be doing big multi-center studies on these things to figure out how we're going to fight back on spinal cord injury and give patients the best opportunity to recover. So let's look at discogenic low back pain. And I know you guys are not familiar with this. Again, I'd love an opportunity to give an entire talk on just peptides. But there's this one thing from Spine Biopharma, Sbmt. It's a 7 amino acid peptide. In their phase 3 trials, they did intradiscal injections, which created a 40% reduction in discogenic back pain at 6 months. Anyone ever heard of this before in the room? Nope. And neither had I until I did the research, because this is the stuff that I obsess about on a daily basis. What can we add to help people to, number one, stay off the table, but if they have to do it, how can we help them to recover and to get better? But I think the implications of the findings are absolutely significant. And imagine combining an intradiscal injection of this with an intradiscal injection of stem cells. What would the results be of that? We don't know because we're not doing it yet, but these are the things that we need to be doing. Here's two peptides, together. A VIP peptide, it's called VIP. So 2023 Advanced Biology, this vasoactive intestinal peptide in mice resulted in 35% less disc degeneration. So this is almost like a preventative thing. Okay, so we need to be looking at these molecules in conjunction with some of the other regenerative tools that we're doing. All right, we'll just switch. Again, I'm going to be switching back and forth because there's so many things that are going to change over the next 10 years. So robotics, right? I've some of my partners in the room. They are very excited about robotic surgery, right? Improving accuracy of screw placement. People know about it, reducing complications, reducing blood loss, shorter stays, allowing us to really, hone in and reduce errors, frankly. I am not a robotic guy, but I see that it's the future. So for our spine group, for our spine and neurosurgery group, we're very much promoting the use of robotics and trying to push that forward. So one of the, I just chose one just because it's something that we are bringing into our hospital systems, but the Globus. It's got exponential precision. The accuracy of screw placement's 99%. It enables faster procedures once you understand how to use the technology, and it works well with AI. It's an AI-guided system, and it's getting better and better over time. So again, the adoption's improving. It's in many centers now. It's growing pretty rapidly, and hopefully we'll be the first in Minnesota to have that particular system. We talked about AI and I was in a couple lectures. We talked about AI. AI improves the MRI accuracy. It can improve recovery from different type of injuries, and you can mix that with different biomarkers. It can reduce errors, for example, in classifying certain types of fractures and classifying certain types of spinal cord injuries. It's really changing spine diagnostics pretty dramatically. These algorithms, and I've been playing around a lot with AI recently, it's almost borderline scary how these things think. Like a couple weeks ago when that DeepSeek thing came out and people were just freaking out, oh my God, America's done because of DeepSeek. I went there. You do the DeepSeek, it shows you how it thinks. And for those of us that, are kind of old school and want to hang on to the past, it's not going to work. So we got to get with the program or we're going to get left behind. And I will tell you, for anybody that's in here that is in medicine, if you don't understand this technology of AI, you will not be doing much in 5 or 10 years. There just won't be anything to do. So just another thing that the society is really promoting going forward. So I don't know if you guys know this, but there's a company, it's called Palantir. And I believe they're going to be the most powerful company in the world. They're an AI company. They run half of the, the defense projects that we have going on in this country. And people know Palantir because of the Defense Department and all we do, and they have a lot to do. A lot of Western countries use Palantir for their basically for their military, but they have a very strong partnership with Cleveland Clinic, and they do a digital twin of the hospital, and by doing that, they're able to cut out all of these inefficiencies in their hospital systems. And if you look at the numbers, it's really dramatic. It reduced wait times by 30%. It boosts, patient transfers. It helps with patient transfers. It helps with predictive analysis, and it has a pretty dramatic clinical impact. And there's a lot of information. I encourage you to look at that partnership between Palantir and Cleveland Clinic. And it is something that I'm going to be trying to really get our hospital systems to look at bringing in Palantir system, because all these hospitals are worried about are their budgets, losing money, the fact that there's so many underinsured patients in our country, and something like these AI programs can make a massive, massive impact. And so it is also going to help us with intraoperative assistance and recovery. So obviously, we talked about the Globus device. We're going to talk about virtual reality, mixed reality systems that are coming out. And then if you go back to the system efficiency study, you potentially could save 50 billion plus by just having AI programs that show you where your inefficiencies are. Not to mention all these AI programs that can help you plan for surgery or tell you who not to operate on. Because you know what? The AI is a million brains, a billion brains, a trillion brains. They're a lot smarter than we are and growing at a very rapid pace. So very quickly on the minimally invasive spine surgery thing, obviously the evidence is there. The reason that I even bring up minimally invasive spine surgery, and like I said, if I had given this talk 5 years ago, all I would have been talking about is this. I would have been like a whole minimally invasive spine thing and how great it is and how we're going to get smaller and smaller and how it's going to, revolutionize everything. It's just a small part, of the pie. The adoption has grown dramatically. It demonstrates better recovery, less blood loss. I think almost all practices now have incorporated some level of minimally invasive, at least one partner or two partners, and anybody you talk to. Our group, many of us do minimally invasive surgery. I've been doing it for a long time, and I think it's pretty dramatic. But what's the problem with minimally invasive surgery? Unlike Moore's Law, if you look at the slide on the left, I just love this slide. So it's number of basically transistors that can fit on those chips. It goes from 100 on the slide, if you look back in the 1960s, to it's an exponential growth, right? 10 million, 100 million, a billion, and so forth. So unfortunately, we don't have Moore's Law. We can't get any smaller. So you're seeing that's a biportal endoscopic surgery. I don't know how much smaller we can get. So I don't know where to go. So hence, the next topic, which is going to be near and dear to the Society's heart, because the textbook, just came out, and I encourage everybody. I think that there's doing a book signing here on Saturday. It's the nano scale revolution. And so nanosurgery operates on the 1 to 100 nanometer scale, looking at nanoparticles, nanobots, nano lasers for these molecular interventions. There's these engineered nanomaterials that are coming out. AI is absolutely going to revolutionize anything to do with nanoparticles and nanosurgery, because it's figuring out protein folding, and I mean in things that people had been researching for 20 years are being figured out in a couple days. And so the ability to develop these nanoparticles and nanobots and other things, I mean, if you really want to dive deep, you have Dr. Kateb's book. It's right there. Go get the book and you'll understand all about it. But it's really a new era of treatment. We can target things like degenerative disc disease and spinal cord injury and spinal tumors. We can target potentially osteoporosis. Just imagine having these devices put in your body and it fixes your osteoporosis by building the scaffolds within the bone. I mean, that's not today, but it's coming, and it's coming fast with the advent of just more rapid learning with these technologies. Pretty fascinating. So these targeted deliveries, you can deliver, to the discs. You can be very specific on the drugs you're delivering. You can have very specific things, and kind of the articles speak for themselves, and you can build these scaffolds. Again, it's beyond the scope of a talk like this, but it's definitely a paradigm shift. I'm very excited about it, and I can't wait to get nanosurgery tools in my hand to be able to offer it, to patients. So hopefully we'll learn more about that over the course of the conferences with some of these nanosurgery talks. So what are the clinical outcomes? I mean, they're already looking at tissue preservation, nerve function enhancement, inflammation control. The FDA, we're making some progress as far as FDA approval of nanocarriers, but that's going to be really important. I love this picture on the bottom on the right, just showing a little robot doing its thing. And so hopefully this isn't too far off in the future, because there's so many things that we'll be able to tackle with the combination of all these things. So one of the last things I want to talk about is really mixed reality and surgeon training. We have a talk coming up this weekend on mixed reality in surgery. In surgical training, I think surgeons are going to be so much better trained. The amount of information that we're going to have to learn as surgeons, we're going to have to know AI and nanosurgery and peptides and stem cell therapies and all this stuff. This is just another way to help us to learn all of these things better. But as far as surgical skill and techniques, skill enhancement, understanding anatomy, reducing errors, and procedure speed. And there's a really good lecture coming up this weekend. I think it's on Saturday, that's going to be talking about utilizing this And this guy was a world champion, not a world, he was the Canadian champion, a wrestler and a surgeon who does a lot of this mixed reality stuff. So not only is it going to help surgeons get better and our technicians get better and have it in the ORs and have all these other things, but there's clear evidence that we can recover our patients better by putting them in these mixed reality devices. So it improves motivation, it reduces need for medication, it has great psychological benefits, and it can absolutely accelerate recovery. And again, the studies really bear it out, and it's only going to continue to grow and to get better. So very exciting stuff coming down the path. This is one of my favorite things, and I actually have an hour-and-a-half talk on photobiomodulation, which at some point I'd like to give. So light and laser therapy is going to absolutely radically change medicine. And it's pretty simple, and I think it's going to democratize a lot of things because it's fairly cheap compared to all the other things that I just mentioned. And so when you shine a light, so a lot of people don't believe, it's hard for me to convince a lot of physicians to think about using light therapy. So the way that it goes is I say to them, and Dr. Scott Sigman's going to be presenting on Saturday, he gave me this nugget when I had him on my podcast. He just asked, ask them, do they believe in photosynthesis? And he said, well, there's not going to be a lot of photosynthesis deniers. So if we can start there, so if you believe that the light hits the trees or the leaves and then it creates energy, the same thing happens in our cells. And so if you shine a light at the right wavelength, and so let's talk first about near infrared light. If you shine it on your mitochondria, there's cytochrome C oxidase in those walls. They absorb that, and it helps those mitochondria to produce ATP. And it can ramp it up by a lot, orders of magnitude. It's a fascinating, science behind it. And through the mitochondrial stimulation, it can really help to heal and repair tissues. It's a fascinating science. Then there's green light therapy. Most of you probably aren't that familiar with even red light photobiomodulation. Green light is interesting. It's actually absorbed in our rods and cones cells, and then it actually goes to a specific nucleus in the brain, and it releases our own body's enkephalins or endorphins, and it's excellent for pain reduction. So the studies are really being done at the University of Arizona, and so they looked at fibromyalgia, they looked at migraines, phenomenal results, and are now studying it along with the U.S. Army on reducing pain after surgery. So the clinical applications are vast. I just had a quick slide just showing the U.S. Army Medical Research Grant for green light therapy in reducing pain management. It has extreme potential to reduce the need for opioids, as does laser therapy and other things. So this is the mechanism of laser therapy. Laser therapy is just more intense. It penetrates deeper into the tissues, and it can have a more profound effect. We're using it musculoskeletal, we're using it for spine, we're using it for concussion management, for dementia, things like that. I'll briefly just zip through this because we're finishing. Obviously, MRI and CT are going to advance. There's some really interesting things going on in the world of CT where the cuts are getting smaller and smaller. Some of these CT scans, there's this Epica CT scan that's out there. It could see a grain of sand in the lungs. It's really rapidly advancing. Nuclear imaging is getting better. Now overlay all of these changes, MRI and CTs, with nuclear imaging and AI, and our diagnostic capabilities are becoming dramatically better. So I'm very excited because we're looking forward to we're going to bring in this really high resolution CT scan and then overlay a PET scan on there. So for example, if somebody has a whiplash injury, I mean, you can get so much more information from something like that. So it's really, the imaging is going to have massive future impact. You could see on the slide on the right, that's a spine. You could see the level of detail that you can see on this Epica scanner. So again, accelerated scanning, predictive analysis, diagnostic efficiency, 3D mapping, it's all coming together. Like I said, the future's bright, and I look forward to coming back every year and seeing how much progression there's been. So in summary, when you synergize all of these technologies, and again, I don't have all the answers. I don't have the algorithm. I can't tell you today, well, use this peptide first and then combine it with this. The studies have to be done. But it's really exciting. So again, just out there stimulate. Imagine we can repair 70% of bad discs, right? Imagine 40% of pain we can get rid of. Imagine we can get rid of misdiagnosis and chronic condition reduction. Again, these are theoretical, but this is where I think that we're going. And we need these clinical trials to really show us the way forward. But we also need the out-of-the-box thinking to develop the right clinical trials to show the way forward. So again, what are the challenges? The regulatory pathways, the cost barriers. Some people brought that up in one of the other lectures, ethical consideration and long-term economics. I think the opportunities are beyond over the top, economically, recovery, clinical improvements, population health. I'll end here. Here's what we need to do. This is what the Society for Brain Mapping is all about and why I'm so excited that I was invited to be part of this. The call to action, we need to get these clinical trials funded. I mean, there's about 1,000 clinical trials between all the stuff that, I just kind of blurb through. Publish your data. If you guys are doing any of this work, even if it's on 10 patients, publish that data. We need it. We need it. We just had this discussion on some of the other talks. Integrate these technologies together and collaborate amongst disciplines, amongst your colleagues here, where there's so many different ideas and thoughts. And I love coming to these things because I learn so much from almost every single person that I run into and talk to. So take advantage of this time that you have here and learn from each other. Thank you.
Stellar talk, and I think Dr. Senekropi kind of summarized where are we heading, and certainly he's one of the pioneers in the field of spine, and we were together at the U.S. Congress.
Yes.
So bottom line is that all of this technologies that we are working in our labs are great, but why is not getting it to patients? So that piece is the policy issue. So, and then the value of that funding can take this type of technology to practice. So, excellent talk. Any questions from Professor Senekropi? Okay, so thank you very much. Okay, our next distinguished speaker is Dr. Aaron Kwangadol. He's one of the pioneers in the field of skull-based surgery and cerebrovascular. Aaron is a full professor of neurosurgery and was director or chair of innovation at the Department of Neurosurgery at USC. So Aaron, good to see you, my friend.
Thank you. So I want to thank the Society for giving me an opportunity to talk this evening. As Dr. Kata mentioned, my name is Aaron Cohen. I'm a neurosurgeon at USC. I think our previous speaker very eloquently discussed the importance of AI and where we're going to go with that. Obviously, AI has many different components, and including the large language models, AI vision, and I want to talk tonight about how we can bring those together in terms of operative planning and performance. This is a talk about entrepreneurship as well. I think people ask often, is entrepreneurship a good idea? From people that you recognize here, Jensen Huang, or from Steve Jobs. And I think entrepreneurship is much more difficult than brain surgery. The amount of challenge that it takes for a surgeon or a team to be able to bring a new technology into the operating room is extremely, extremely challenging. Much of it has to do with regulatory in medicine and medical device, and really the so many conflict of interest that are present in medicine these days. So we talk a lot about technologies that sound great, but bringing them to the operating room is almost impossible. But tonight I want to give you a perspective about where I started and how was my journey. I started with Neurosurgical Atlas, which is a nonprofit organization. Thank you. And it's for neurosurgical education and innovation, and it has about 1,300 surgical videos that took us about 12 years to put together, 9,000 original illustrations and 560 chapters, more than 64 terabytes of data. It took about 8,000 surgeries to put that together. And it really led to us getting the Vela Magnus Medal from all the Scandinavian countries. It's number 11 in 100 years, which really demonstrated the amount of value that the world has had for the work of this nonprofit. Tonight, I want to talk to you about this art of microneurosurgery, and this is an article that I highly recommend in Journal of Neurosurgery for you to refer to about what it means. People that obviously have defined excellence are somebody like Michael Jordan or Michael Phelps, who really show that it's all about perseverance and what it takes to go to the next level, and it's not different in entrepreneurship. So tonight I'll talk about two elements. It's the large language model that are RAG-based. RAG stands for Retrieval Augmentation Generation. And what RAG does is that it uses a private data that is not available to ChatGPT or any language model, Sonnet or DeepSeek or Grok 3 or whatever language model you want, and it makes their response extremely contextual. In other words, if you're a neurosurgeon and you ask a question, it's going to answer back in an extremely complex, high-level response to you. If you're a patient and you ask the same neurosurgery question about your procedure, it would put it exactly at the level of your understanding. And that's the new generation of large language models. Not to have everyone go to ChatGPT and get an answer, but different people go to different language models and get the answer in their own logic. If they're a salesperson, if they are a patient, if they are a resident medical student. And the era of large language models and the basics of generative AI, we're not going to go through tonight, but there's no question that these large language models are going to replace much of the decision-making process that neurosurgeons and other physicians will take on. There's obviously challenges to anything to start in terms of these low risk of hallucinations, but most often these are pretty easily overcome. And as you can see, the new models like DeepSeek with their reasoning capability make that almost hallucination-free phenomena possible. And if we put RAG on top of that, which we did to create Atlas GPT, instead of ChatGPT, our product is called Atlas GPT, it would really do zero hallucination. It gives you references. It's no longer a black box. It is very minimal bias, and the updates are very easy to do. So what we are talking about really today is bringing this Atlas GPT, which is a RAG-based model, to be able to provide a very contextual answer for a medical student, separate from a resident, separate from an advanced neurosurgeon using this private data. And here's the mechanism that you can see here. It's a certain amount of data that are private, 18 peer-reviewed journals of top neurosurgery journals, and we put them into this prompt, be able to direct the language model to provide a response that's extremely appropriate. And then there's different personas. We have a medical student persona, resident persona, advanced neurosurgeon persona, and these allow for a very catered response to a very difficult question. Obviously, these are extremely challenging projects that have required a large amount of private data to make possible. This is example of non-medicine that, for example, if you ask a question from ChatGPT, tell me about hippocampus, it will give you maybe an answer about hippocampus as an animal. But if you get an answer from Atlas GPT about hippocampus, it will give you extremely deep data about neural network of the hippocampus in the brain. And that's really what the difference between a private data is. Obviously, a lot of people question if these models are accurate. With RAG, it is really possible to make the response hallucination-free. In fact, I'll present some of the data that when the Atlas GPT took the national exam of neurosurgery for board certification, its accuracy rate was 96%. That's higher than any human ever that have gone through the exam. And the other 4% was really, questions were somewhat arbitrary in terms of radiosurgery after subtotal pituitary tumor resection. One can argue either way. The case applications for Atlas GPT is management strategies for complex patient cases. You really can run a patient by it and it would do much better than the most advanced neurosurgeon I have ever seen. It's not uncommon that I ask a question and I get an answer and I think it's absolutely wrong, but when I read it more carefully, I was wrong. I just did not consider that option. So the most common reasons for people saying the answer is wrong for RAG-based model is because the person who is evaluating the response is wrong. There's many other ways, triaging patients for allied health, coming up with new project, customized patient materials for education. There is a huge host of applications for Atlas GPT using these RAG models that provides an extremely valuable and efficient way for these models to provide value in our armamentarium. ChatGPT, again, is a very general model. It's for general population, and these RAG-based models are for individual professional specialties. In personal neurosurgical consultation, decreasing administrative burden and neurosurgical quality control. I can ask Atlas GPT to dictate an operative note of a very difficult operative procedure for me without even being there. And I can tell you, as long as I give it some very basic concepts, it gets it perfectly right. The 3D anatomy of the dissection, how you're going to go through and do it as if it was there and did it for you, as if it was the surgeon there doing the surgery. So that was the concept of Atlas GPT. The second concept is Atlas Surgeon. How can we use imaging and marry it with large language models to bring a new level of understanding? Currently, ChatGPT and large language models, in the state they are, they can't really interpret images very well, including MRIs. I think Grok 3 can do some work. ChatGPT can give you some basic responses, but again, these are relatively basic in the area of AI vision, or if there was ChatGPT's large language model, AI vision is corresponding element in that arena. So neurosurgery has remained the same. We have brought a lot of technology, but we haven't made big big changes going forward. And the planning in the operating room can be challenging. So tonight, I want to talk to you about another concept of intraoperative planning and decision support, dynamic intraoperative guidance, how it can be married with robotic systems as well as AI analytics. Preoperatively, how can we have an AI model that provide to us the approach to any location in the brain? That would be attractive. Plan the craniotomy or set up and intraoperatively be able to overlay that on the brain. I'm going to talk to you about Atlas Pathfinder, Atlas OR, and how it can integrate into robotics and how it can improve some of the workflows. So this is the phantom brain that we created, and it took 12 years to create a 700 million polygon of a normal human brain. It has every artery, every vein, every deep structure, every tract. And what we do is that we use this model and we create decision algorithms that is a library of decision support. How to approach that area of the brain, what corridor to use. And then this brain, which is we call the Atlas phantom brain, has its own axial, coronal, sagittal components, just like any other brain MRI. And here you can appreciate some of the detail of the anatomy of this normal brain, but obviously this is a normal brain. This is not an individual patient brain. So how can we use all this? At every second, 11 decision points are decided using the GPU to approach a lesion in the brain. How can you make that specific for an individual patient? This is another example of this. You creating a craniotomy using a volumetric brain or a patient's head. We can do all of that, but again, that's on a normal patient's head. You can create these fancy drills and make it eye candy, but so what? It's good for education. How are we going to bring that to the normal brain? And so the algorithms we use, as you can see, it can provide an approach to a tumor using the cone and degrees of freedom instruments you need, as well as the blue line or curvilinear that shows the approach through an interhemispheric approach. So that was the work we did for about 8 years. We felt very proud of ourselves. But then after all that work, like, so what? How am I going to apply this to individual patients? And that's where the extreme amount of shear work started. And we had to create an AI algorithm that can essentially segment every structure in the brain of every patient and use that as a label map to co-register it to the phantom brain. In other words, we had to deform every patient brain. We had to deform the phantom brain to every patient brain and provide decision support. And that's what it took really 4 years to be able to create this algorithm where you can select an image within MRI sequence, image co-registrations, and be able to segment 98 segments of the model, including veins and arteries. And this is what the work has been, is to create a virtual twin of every patient's brain. And what we do is that we get the patient brain. We have already used about 2,000 MRIs of patient tumors to train the model to segment every piece of the brain, including the tumor and edema. And every object in that patient brain is co-registered to the phantom brain. So I create a virtual twin of the patient brain. And you can see the colors in segmentation. And what we do is that we bring that patient, this is that virtual twin that is created based on just 4 sequences of MRI. The arteries, the veins, everything is segmented. No MRA was done, no CTA. Obviously, the vessels are not as high quality, but it's good enough for surgical planning, and you don't need to do the CTA and additional work. So after that, we created a virtual twin of the operating room, where the operating room can decide for you how to position the patient. And that's our virtual twin OR. And this was with some collaboration with NVIDIA, by the way. And it just shows that everything in the virtual twin world has been created and the patient is positioned. And you can go ahead, and that's again for the phantom brain. You can adjust the head of the patient in the virtual world and really look at the view through the operating room in the right lower corner and be able to plan your operation. Again, this is another view of that. If you enjoy eye candy here for some of the, and that's patient specific. So that's the individual patient with a sphenoidal that's been brought into the virtual twin operating room for you to plan. And there are other applications of this, obviously. And this is another sort of video demonstrating the applications of the Atlas surgeon and how this can work in terms of bringing this technology and segmentation, Atlas GPT segmentation we talked about, combined together, planning the position of the head with giving you feedback where this pins could slip potentially and create risk for the patient in the operating room. And that's really become the roadmap for us for the next stage, is that use this segmentation, use AI vision as the core technology, and then use it to marry it with large language model for decision support, pair it with a phantom brain for intraoperative planning, and the biggest, obviously, application would be to auto-generate radiology reports. In other words, there will be very minimal need for a neuroradiologist to dictate every report. The AI vision segments the MRI. It gives it to a large language model. The large language model, within a few seconds, generates a very accurate neuroradiology report that can be proofread by a neuroradiologist for accuracy. Obviously, we're not planning to replace neuroradiologists or replace surgeons or anyone. It is the era of really being able to augment care to what we call among our team, liberate greatness. I think we want liberate greatness of every surgeon, every physician, every radiologist, every medical student. And AI is here to liberate greatness. It's not about replacing people. And with that, I wish you a great meeting. I want to thank you again for this opportunity.
Thank you, Dr. Adolphe. That was a fantastic talk. So, when you talk about the Atlas and surgeons, at least for neurosurgery, do you find that there is sometimes, when it comes to sharing surgical, especially intraoperative mishaps,
Yes.
it becomes almost like, you only talk to certain people about that.
Yes.
Especially at meetings, complications
Yes.
are very. So do you think that's something that we have to get around and maybe use that as a starting point
Yeah.
to have this, before we start talking about the normal stuff, getting that out of the way?
Very well said. It's amazing when you went just to the meat of the matter. The way Neurosurgical Atlas was started is that I recorded my worst videos of intraoperative aneurysm ruptures in 2005. And I went to Indiana, started my practice in Indiana. It was the largest brain surgery practice in the country. It was, you could run 5 or 6 operating rooms at the same time. I had 2 fellows. We did about 400 to 500 at times surgical cases a year. It was extremely centralized. There was no competition. And so there were days, not very unusual at all, we did 10 craniotomies before 4 p.m. Most of them, none of trauma. I didn't count traumas or basic craniotomy procedures. And in that environment, I really had a chance to get into a lot of trouble, especially the first 5 years of my career. If you go on Neurosurgical Atlas, there's about 65 intraoperative ruptures or disasters, just 65 intraoperative ruptures. There are many others. And I can tell you that there is 4 or 5 of those that every time I watch those, I have to take a break because I get extremely almost, it's so egregiously threatening to look at the video after the fact. And it's so extremely impossible to save the patient at that moment that it becomes disturbing to watch another video. You just have to take a break. And I was the surgeon. That was a video after the fact. That wasn't me at the time when that happened. And so those videos became the most valuable and the starting point of Neurosurgical Atlas. I remember people were saying, oh, you're going to devastate your career. You're going to go and put all these videos for everyone to watch. Aaron, you're going to be gone. This is extremely dangerous. But I think it was the most valuable contributions I ever did to neurosurgery. Demonstrate how much I got into trouble. Because I think people learned a lot. People don't do that anymore, and I think that's a big problem. Am I answering your question, or maybe it became a psychotherapy session for me?
This is something, again, when you watch your own complications, you become your biggest critic. And of course, when you lose a
Yes.
patient, it becomes even more. I mean, because you care. That's all that means.
Yes.
And we all care. But you know, it definitely helped give me some clarity and some closure as to something I've been thinking about. So I
Right.
appreciate it.
No problem. But I do believe watching yourself operate. I remember the first year when I started practice, I videotape all my surgeries, and I would then go watch afterwards, and I would take out the areas that I actually did something. And I would look at the video, and everybody in the OR was telling me how great the case went. And I watched the video, and I thought, my God, I look like a bear with mittens on. That was one of the old neurosurgeons who would walk into the operating room, and he would tell the resident, oh, you look like bear with mittens on because you can't even hold an instrument. And that was the case. And everybody thought the case went great. And I can't tell you how valuable those videos were. Anyways, enough psychotherapy for me. Any other questions here that I can answer for you guys?
Okay, well, I have a question. Well,
Go ahead.
first of all, congratulations for being honest.
Thank you.
And I think honesty in medicine is rare now.
Yes, it is.
And everybody wants to say I'm the greatest, but we both know we learn more from our mistakes
Yes.
than our accomplishment. And really, that's
I
the
agree.
key here. And so in terms of the AI, the world of AI, so
Yes.
we have a lot of that in this conference. How do you see AI revolutionize neurosurgery? In a sense that basically force the neurosurgeons to be honest with themselves and really just learn from their mistakes. So, basically, better ability to train, better ability to detect mistakes or even predict and prevent them.
Yeah, it's, when you say how are we going to teach physicians or neurosurgeons in particular, you're asking for an extremely tough task, because everybody believes they know everything, right? How could you walk into the operating room and take care of a patient and don't believe you know everything? So I think the same fact that makes us so successful hurts us the most. The fact that we don't want to be honest that, in fact, AI can do a better job. And we are very resistant to that because we all feel threatened. Physicians, neurosurgeons, the most, feel threatened by any tool that can potentially tell them what to do. But if we don't do it, somebody else will do it for us. It's not a matter of when or how. It's not a matter of if or how, it's a matter of when. I think the AI models I would say within 4 years, we will have a model that would be board certified in psychiatry and would actually perform significantly better. Not even 5, within 3 years. I think within the next 5 to 10 years, we'll have a number of specialties will have AI-driven decision support. That will be a requirement for the patient case to go through that first. And if people resist, I think it's going to be tough because I've always believed in a statement, and I know whoever said that, he said, You can be either someone who watches what things happen, you can be someone who makes things happen, and you can definitely be someone who wondered what the hell happened. And the decision is yours, where you want to be.
Well said. Well said. Well said. Thank you, Professor. Definitely, we want to be the ones that make things happen. And with your support, this organization will push that forward, and we're delighted to collaborate. Thank you. So with that, I will conclude the sessions today and invite you to join us to the opening reception. So if you have any questions from Professor Cohen Gadol, he will stay around for a few minutes. And yeah, so thank you very much and have a great day.